It's 7 a.m. on the respiratory floor. Out here, and on your exams, the difference between a routine shift and a clinical emergency comes down to recognizing subtle clinical patterns before they escalate. We start in room 1. Your patient has advanced COPD, and his monitor is blaring. Oxygen saturation has dropped to 85%. The instinct to crank his oxygen to the maximum is your first major hurdle. This diagram shows the physiological feedback loop in a chronic CO2 retainer. In advanced COPD, the brain eventually stops using high carbon dioxide as the trigger to breathe, switching instead to low oxygen levels. If you flood the system with supplemental O2, you accidentally remove that natural drive to breathe. The correct response is a slow, controlled increase. We use a nasal cannula for low-flow delivery, targeting a saturation range between 88 and 92%. Respecting the body's adaptation to chronic CO2 retention prevents the lethal overcorrection that often leads to respiratory failure. Moments later, the patient becomes acutely anxious and starts gasping for air. In respiratory distress, the priority is mechanical. We immediately move the patient into high Fowler's position, sitting him at 90 degrees to drop the diaphragm and expand the lung base. To manage the rapid, panicked breathing, we coach him through pursed lip breathing. Inhaling through the nose and creating a slow, prolonged exhale through pursed lips creates the back pressure needed to keep the airways open and push trapped CO2 out. Once his breathing stabilizes, we administer his maintenance dose of tiotropium. This anticholinergic relaxes the airways, but it also dries the mucous membranes. If he complains of a dry mouth, we treat it as an expected side effect. Note his physical appearance, a barrel chest paired with very thin legs. Advanced COPD is a high-energy state. He is burning calories just to breathe. To support him, we provide small, frequent, high-calorie meals that won't exhaust him during the day. Effective COPD management relies on these baseline mechanical and nutritional priorities before escalating to pharmacological interventions. At 11:30 a.m., the floor focus moves from chronic management to urgent procedural care, where the airway, breathing, and circulation, the ABCs, take center stage. We are prepping a patient in room 3 for a thoracentesis to drain excess fluid. Safety during the procedure requires this specific posture, sitting upright and leaning forward over a bedside table to spread the ribs. 1 hour later, the patient is suddenly dyspneic and tachycardic. Post-thoracentesis distress like this points to one specific structural complication, a pneumothorax, or a collapsed lung. Sudden vital sign shifts following a chest procedure require an immediate investigation to confirm the structural integrity of the lungs. Down the hall, a patient has just returned from a bronchoscopy, where a camera was passed into the airways. They are now exhibiting a new, high-pitched sound on inspiration. That sound is stridor. As the diagram illustrates, the trachea is rapidly narrowing due to post-procedural edema. This is an immediate airway emergency. Do not continue routine monitoring or wait for a second set of vitals. Report this finding to the provider immediately. Post-procedural respiratory distress requires an immediate transition from observation to airway escalation. At 2 p.m., a rapid response call comes from room 5. The patient is experiencing a severe acute asthma attack. They are struggling for air with audible wheezing. In an acute attack, the priority is bronchodilation. We administer albuterol first to open the airways as quickly as possible. Shortly after the albuterol dose is given, the patient's heart rate rises and their hands begin to visibly tremor. These are expected physiological responses to the rescue medication, not reasons to delay treatment. But then the situation takes a dangerous turn. The wheezing stops completely, and the patient suddenly becomes lethargic. That silence marks status asthmaticus. As the bronchial tube occludes from inflammation and mucus, air movement stops entirely, which is why the wheezing disappears. This requires high-flow oxygen and immediate IV steroids. In a respiratory crisis, a sudden absence of breath sounds is a more imminent threat than a loud, audible wheeze. By 6 p.m., the immediate medical crisis is over. We are preparing the patient for discharge with a prescription for fluticasone, a daily inhaled steroid for long-term control. Discharge teaching for steroids is critical. Patients must take the medication with food to protect the stomach and monitor for fluid retention and low potassium. At 7 p.m., the clinical shift finally concludes. Success on the floor relies on a strict framework. Position first for distress. Use controlled O2 for COPD. Prioritize rescue inhalers for asthma. And escalate sudden post-procedural distress. Mastering these specific clinical rules makes the correct response an automatic reflex.